السلام عليكم دكتور إيهاب.
دكتور إيهاب، أهلا وسهلا.
Okay, do you hear me?
يس.
Can
يس
I
دكتور.
start?
تمام يا دكتور، ما بيقترحوا إن هم بيصلوا دلوقتي يعني.
Huh?
أذان المغرب. أذان المغرب بيأذن في مصر دلوقتي. لو
So
حضرتك حابب
what? So do you want me to wait?
5 minutes بس يا دكتور.
اللي يناسب حضرتك يعني.
يناسبكم انتوا؟
إيه رأيك يا دكتور أحمد؟
ماشي يا دكتور، نستنى 5 دقايق حاضر بعد الصلاة.
For Amir, do you see my
السكرين ظهر يا دكتور.
yeah, okay.
Can you full screen دكتور إيهاب؟
Uh,
تمام كده.
أهلا بحضرتك دكتور إيهاب.
May we start?
اتفضل يا دكتور.
Okay, thank you. Bismillah ar-Rahman ar-Rahim. Okay, we are back to our presentations, lectures, and meetings. And these meetings are made for any practicing neonatologist or any other person working in neonatology, like nurse practitioner or even nurses, for pediatricians who take care of babies, and even for medical students who are studying their neonatology courses as part of their pediatrics lessons. And we do MCQs, and the idea behind the MCQs is not to get the correct answer, because if you get it, well and good. If not, no problem. The question might be very easy, might be very tough, but the goal is to train ourselves to do very smart clinical approach, very smart diagnosis and differential diagnosis. And you have to do this in no time. The more you train yourself, the more you will be practicing better. And in neonatology, you have to make your decision in no time, sometimes in a glimpse, sometimes in a fraction of a second. And your decision is life-saving most of the time. And the idea behind trying to answer MCQ is to look for the keywords. Any scenario or vignette that you are given has keywords. And you focus on the keywords, and it's like a puzzle. You collect all these keywords together, and then you start thinking, what are the possible differential diagnoses, and what labs we should do, and then what can we exclude, and what is left to be the actual diagnosis. This is the way you have to think in your question, in your daily practices. So this case is a 2,800 grammer girl. Mom was 28 years old, primary. Baby is born at 38 weeks by C-section because the baby had some fetal distress. Otherwise, everything is unremarkable. Apgars were 6 and 8. And this baby is breastfed. And at the age of 1 hour, we started to have some issues. Sorry, at the age of 20 hours. Breastfeeding was started at 1 hour of age, and the baby did very well. But at the age of 20 hours, she started spitting of milk. Spitting of milk, which may or may not be normal. We don't know. It's just the beginning. Could be normal, because regurgitation and spitting of milk is very common, especially in the first few days of life. However, the team taking care of this baby started doing gastric lavage. What they do with the gastric lavage is they insert an NG tube or an OG tube to the stomach. They spread the contents, start washing with normal saline several times till the aspirate is clear. And one of the points we are going to discuss here is the practice of doing gastric lavage. After a while, here starts the problem. The medical providers noticed fresh bleeding through the nose and mouth. And when you have a baby who is bleeding through the nose and mouth, you know that there is most of the time copious amount of bleeding. So, and then the baby became pale, shocky. This baby went rapidly into hypovolemic shock, meaning she lost a good amount of blood. And blood was still coming out through the NG tube. Heart rate was 170, which is high. Capillary refill was more than 3, which is not normal. But the temperature was okay. However, the abdomen was soft, non-tender, non-distended, and with audible bowel sounds. And then the baby started to have melena. And by melena, when you have a baby with melena, meaning that this baby is having bleeding coming from up, higher IGI, upper GI bleed, and it's altered through passage in the digestive system. And melena is not a good sign. Okay. However, the baby was hemodynamically okay. There was no petechiae or bruising. This is important. There is no family history of bleeding. This is important. Baby was given vitamin K at the time of delivery. So they managed hypovolemic shock with fluid resuscitation, normal saline, and then started giving another dose of intravenous vitamin K. They give fresh frozen plasma, packed red cells, and omeprazole for injections for gastric irritation and possible ulcers. So they did CBC and DIP, which was benign. They did coagulation profile, which was which was normal. They did sepsis workup, which came back normal. And then they did an X-ray, no free air in the abdomen. They did Doppler ultrasound, and there was no evidence of malrotation. The superior mesenteric vein and superior mesenteric artery were in normal relationship. And even the stomach was not distended. And the pylorus was unremarkable. So before we go into labs, what is your differential at this point? And when you have a baby who is bleeding, you have to decide as much as you can, what is the site of bleeding? Where is this blood coming from? And then you start thinking, is the cause of the bleed because of local issue at this area or because of a systemic disorder like coagulopathy or bleeding disorders? And is the bleeding something benign? Because we can, I don't say bleed, the blood, is it because of something benign or it is because of something serious? And for the site of bleeding, it might be upper GI or lower GI bleed, depending on relation between the site of bleeding to the ligament of Treitz, which is at the middle of the duodenum. Okay, so at this point, what are we dealing with? Is it upper or lower GI bleed? And everybody's allowed to answer if you can. Is it upper or lower GI bleed? Are you allowed to answer or you are unable?
دكتور الدكاترة بيجاوبوا في الشات كلهم كاتبين upper GI bleeding في
Upper
الشات.
GI. Yes, correct. Upper GI, definitely. This is an upper GI. Is it benign or something serious is going on? Definitely, this can never be benign. The baby is shocky and pale and required transfusions, fluid resuscitation. Okay, and what is the cause? Is it a local cause or a systemic cause? Like coagulopathy, bleeding disorder, and the most common, especially this is a girl, not a boy, the common cause at this age is vitamin K deficiency, which could be either early, classic, or late, and we discussed it several times. Baby was given vitamin K initially. So do you think the cause is a local one or a systemic problem? It is very obvious that this is a local problem, definitely. It's not a systemic, and this is going to be confirmed with these labs. Hemoglobin initially was 8 and then went up to 12 after transfusion. The red cell count was not bad initially. They didn't check it actually. Platelet count was normal. So it is not platelet disorder. White cell count is appropriate, not dealing with sepsis. And PT and PTT were within normal ranges, although they are using these reference ranges, which I don't think is accurate. It should be in the newborn baby, the numbers should be higher than that. So whatever this baby had was within normal range, the PT and PTT. And this is going to rule out most of the coagulopathies and the vitamin K deficiency. Okay. INR was borderline. Other labs were normal, within normal range. Okay. So what is your differential? Here comes the most important part of this question, which is an easy one actually. But I wanted to start with an easy one just to show you how we manage, how we proceed, how we think. So what is your differential? What is your differential? Number one, what do you think that the most common cause for this problem is? I don't see your comments. I don't know how can I reach them.
في الشات يا
من
دكتور.
الشات يا دكتور.
سوري،
حرك الماوس
حضرتك
حرك
شات.
الماوس على ايه؟
لفوق
شات.
هتلاقي الزرار فيه تشات.
شات.
يا دكتور.
Chat. Okay. Click on chat. Some I see. No. I see swallowed. I saw swallowed blood. I saw somebody writing swallowed blood. Yes, swallowed blood. Dr. DN wrote swallowed blood syndrome. Do you think this is swallowed blood? I know this baby was breastfed, but we didn't see any in the vignette any comment about like breast fissure or soreness of the breast. And this baby was shocking, had a profuse amount of bleed, which can never happen with why if the baby swallowed blood, why should the baby become shocking and hypotensive and tachycardic and pale and require blood transfusion and fluid resuscitation? Definitely, this is not the cause. Trauma from lavage, correct. Okay, if we are looking for trauma from lavage, is it just like ulcer or irritation or it's perforation? You have to decide if this was a perforation or not. Was this perforation? Yes or no? Was this gastric perforation? Yes or no? There is nothing in the vignette that shows that baby had perforation. Abdomen was not tender, was not distended. X-ray didn't show any free air. The stomach looked appropriate. So definitely this baby was lucky enough not to have gastric perforation. Okay? So let us proceed. So we ruled out systemic causes. We like platelet disorder, like coagulopathy, vitamin K deficiency on top of the list. And then comes local causes. Okay, we thought of trauma because of the gastric lavage, but might be there is another local cause. Was this baby necrotizing enterocolitis? Definitely not. This baby was healthy. It got choky because of the blood loss, but after that, baby became hemodynamically stable. There is no pneumatosis in the X-ray. The abdomen was not tender. It doesn't look like necrotizing enterocolitis. Local malformation, arteriovenous or arterial or venous, it's a very, very remote possibility, but it is still there. And you cannot rule it out unless you do scope. But you have a good history of the gastric lavage that makes you think of the trauma. So swallowed maternal blood, definitely not. Hemorrhagic disease of the newborn, vitamin K deficiency, no. Coagulopathy, no. Sepsis, no evidence of sepsis, clinically or by labs. DIC, why this baby will get DIC out of the blue? And there should be low platelets, prolongation of the PT and PTT. They didn't check for fibrin degradation products, but other parameters of DIC were not present, and there was no oozing of blood from different sides of the body. It's ruled out. Volvulus and malrotation was ruled out. Gastric perforation was ruled out, and vascular malformation. So we didn't mention the actual diagnosis. And this was noticed when they did scope. When they scoped this baby, they found blood clot in the fundus of the stomach. And it is iatrogenic. And be careful because we do hundreds of NG tubes every day. Either for diagnostic issues or for feeding of the baby. So this is going to be part of the lesson, of the ongoing lesson today, is how you should practice as much as you can of doing NG tubes so you can perfect it and don't cause any problem to the baby, because this is a very simple and common and frequent procedure, but the outcome might be very serious, like excessive bleeding or even perforation, okay? And this is what they found when they did the endoscopy, and this is the ulcer with a large blood clot, that meaning the baby bled a lot, a good amount of blood, okay? So what happened to this baby? The baby was treated conservatively. It didn't require surgery because there was no perforation. And they continued the omeprazole infusion. And I don't know if you are in this practice in your NICUs or not, but we use omeprazole infusions a lot for babies who have bleeding, upper GI. And also we can see bleeding in, this was not mentioned in the differential diagnosis, but because the baby was not very sick. If you have a very sick baby, especially the preterm ones, and the baby is very stressed out, there might be what they call stress ulcers in the stomach, and this could bleed. And that's why they do omeprazole infusion for those babies who are very stressed, very sick, preterm babies. The baby was started on OG feeds, gradually increased, baby tolerated the feeds, baby went home, was followed up by a GI specialist, and baby did very well. So, very important issue is to take care of performing NG tube and put into consideration the possibility of gastric trauma or gastric perforation. And you should know the signs of both of them. And if it happens, you should diagnose it as early as possible. You should interfere as early as possible. And if there is perforation, the treatment is surgical. Okay, great. And what are the major risk factors for perforation or trauma? Low birth weight. And of course, using the OG tube by an unexperienced person. And the tip could be very traumatizing, tip of the tube. And we're talking about the perforation, and if there is perforation, there will be free air or fluid on abdominal X-ray. So what are the, how you manage these cases, whether trauma or perforation? If it's perforation, definitely you'll do surgery. In addition to that, you will do whatever you do for trauma, which is maintain airway, A, B, and C, as we do in every resuscitation of any baby. Okay. A neonate with clinically severe nasogastric bleeding receiving acute resuscitation should get an early intravenous proton pump inhibitor, PPI bolus. This is a rule of thumb. You can give it boluses or you can give it as a continuous drip. You can use it both ways. So another lesson, gastric lavage. This practice should not be practiced as much as we do because it is not a safe one and it is usually useless. Gastric lavage is not recommended to check perfect gastric aspirates or in acute critical upper GI bleeding due to the risk of iatrogenic trauma. Even if the baby is bleeding, don't do gastric lavage. This is important. So try to withhold doing this procedure as much as you can. It's usually useless and maybe harmful. Don't do it to check gastric aspirates or to remove irritants from the stomach of the newborn baby. Or even if the baby is bleeding, gastric lavage will not help stop bleeding, but it might make it worse. Might make the trauma worse. Okay? Rigorous and continuous training sessions should be emphasized for common procedure skills in the neonatal unit, such as passing an NG or OG tube. Careful handling and insertion followed by combination of the position of the nasogastric tube, confirmation of the position. Usually you confirm it with an X-ray. Can reduce iatrogenic cases of gastric trauma. Lessons. Iatrogenic gastric trauma is a rare condition, but it can happen, especially in preterm babies. Gastric lavage should be discontinued and stopped as a routine. Procedure of feeding tube insertion, although common practice, must be done vigilantly, carefully, very cautiously. And you should know the complications with a trauma or perforation. Any questions, any comment, any suggestions? Okay, we proceed to the next MCQ. I will skip this one because although it's very important dealing with early onset neonatal sepsis, but the answer depends on if you are using whatever is used in this MCQ to diagnose the risk of early neonatal sepsis. They have a calculator based on multivariate statistical models. And depending on the number that you get at the end of doing this calculation, you will decide what to do with a baby who is suspected to have early onset sepsis. Do you have to do full sepsis workup, blood culture, CSF, start antibiotics, or you just observe the baby and for how long, 12 hours, 24 hours, and or any management in the middle? So I will skip this because it's I don't believe you are using this. You are using this calculator, okay? Then I will go to case number 3. This is a 30-weeker. The problem started immediately after birth. There was blue discoloration of the right hemiscrotum in the delivery room. Blue discoloration of the right hemiscrotum in the delivery room. Otherwise, mom was 32-year-old, gravida 1 para 0, white woman, maternal history, asthma, prolactinoma, hypothyroidism, not important. And prenatal survey, everything is unremarkable. Baby was delivered by C-section for non-reassuring fetal testing. Birth weight was 1,490 grams. There is no family history of congenital genitourinary conditions. Presentation. Initial interventions following admission included intubation, surfactant administration, something not related to our current problem, and UVC, sepsis evaluation, antibiotics. There was the right testicular exam remained abnormal in serial exam. Otherwise, everything looked normal in the exam. The baby was not in acute distress, and the skin was well perfused. I'm skipping the comment on all other systems because they are normal. I'm focusing on the keywords. Keywords. The abdomen was soft, this is important, non-tender, non-distended. But there was persistent bluish hue, swelling, and firmness of the scrotum. Patent anus, no sacral dimples. CBC and F was benign. There was no evidence of sepsis or infection. This is important because whatever is going on might be because of infection. H&H appropriate, platelet count okay, blood gas is appropriate. So they did scrotal ultrasonography with Doppler, which solved the problem. What is your differential at this point? A preterm baby who is having edema, bluish discoloration of one of the hemiscrotum left, persistent. Otherwise, everything looks okay. What do you think is going on? Testicular torsion should be excluded. Yes. 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 Torsion. Everybody is talking about testicular torsion. Okay. What is the differential diagnosis of testicular torsion? Exclude hematoma. Good. Yeah. Trauma. Yes. Good. A hernia that is strangulated. Yeah, but usually if you have a hernia or hydrocele that is complicated, usually there will be also a scrotal mass. And this baby did not have scrotal mass. So epididymoorchitis, yes, it's a good thing. Okay. I see somebody talking about the bell clapper sign. Okay. Teratoma, maybe. So yeah, this was easy. And also, so this is their differential. If you have an acutely swollen and tender hemiscrotum in a newborn baby, you think of hematoma. Of course, common things are common because of trauma, or hemorrhage of ectopic tissues, testicular torsion, and there is another item called torsion of the appendix. These are two different clinical presentations, and the treatment is different, but they might look alike in symptoms initially, especially in an older baby. But if you have a chronic swelling of the hemiscrotum, which is not in the case, it's just because we're talking about this issue. It could be a hydrocele, which we see very common, inguinal hernias, we see a lot. A syndrome called splenogonadal effusion, it's very, very rare. Or supernumerary testis, or testicular neoplasm. What happened is that they took the baby to the OR, and this baby was lucky, because when you know the actual diagnosis, you will be astonished. Because this is the ultrasound and they did ultrasound and then did color with a Doppler. The right testis also was abnormal by ultrasound, and it shows heterogeneous echo texture and absent blood flow. Okay, so both testes were abnormal. This baby was lucky. And the left testis shows, this showed arterial blood flow in the testis. The testis is normal in size and appearance, arterial blood flow, and venous blood flow below. So one of the testicles by ultrasound was abnormal, the other one was looked normal, but what happened in the delivery room, in the OR, was astonishing. This baby has bilateral testicular torsion. It's a very unpleasant surprise. And if this baby was not taken to the OR and was managed conservatively, definitely this baby will lose both testicles and will be sterile and will have endocrine problems in the future. And when we see the discussion, the management of the torsion of the testicle in the newborn baby, especially if the baby is preterm, is not easy. It's very, very challenging. And there is a lot of controversies. And different people has different management issues. Because this could start prenatal or postnatal, and the postnatal might be early or late. And it could be one side or both sides bilateral. And the scary issue about this, it could be silent. Testicular torsion in the newborn baby could be silent. So if it is silent and bilateral, this is a catastrophe. And if you check that one of the testicles is abnormal, you have to look for the other one. Because if we have a normal testicle, at least if you decide to do conservative management, you will be sure this baby will develop normally. But if you find both testicles affected, you have to interfere. No way. Okay? And so there was, when they did exploration, they found hemorrhagic and firm right testicle that had detrused. The left testis exhibited 270 degrees torsion with normal perfusion. It's confusing. The one that was actually in torsion, the blood perfusion was not bad, and the other one that they didn't find like very clear, like this one, 270 degrees, was having affected blood flow. Okay. However, they tried to save the right test, and what they did is, because you need to know if what happened is reversible or irreversible. So, although it did not show signs of perfusion, yeah, the right tests did not show signs of perfusion after being wrapped in warm gauze and was removed. They tried to save it. It was not viable. They had to get rid of it. And what they did to the left one was detorsion and archaeopexy, and they saved the one of the testicles. So initially, I forgot which one was affected clinically initially. It was the left. It's confusing because both were affected. And the right, so okay. So the right one was the one we started with, and the one that had diminished flow, and the one that was not viable, and the one that was removed. The left one was accidentally found to be in a torsion also, but it was saved. Okay? I will not go into the details because it's mostly urology and pediatric surgery issues, but our role as neonatologists or pediatricians is to have very high index of suspicion for torsion, and don't hesitate to do ultrasound, Doppler. Don't hesitate to consult urology, and try to save the testicles, if not both, at least one of them, of the newborn you are dealing with. When I send those questions to you, you will read all these details if you are interested. And the gold standard is the ultrasound. Okay. Importance of a careful testicular examination in the delivery room in identifying and formulating a differential diagnosis for testicular abnormalities. This is extremely important. It is not, you are not looking for a common problem, but if you miss it, it is a catastrophe, especially if it is bilateral, or if one is affected and the other one is silent, the same as we had in this scenario. So, careful testicular examination in the delivery room in identifying and formulating a differential diagnosis for testicular abnormalities is extremely important. And then talking about the bilateral and the silent and the effect of this problem on fertility and endocrine insufficiency. And this table shows you some of the differential diagnosis and how you differentiate between the torsion, testicular torsion, hematoma, hydrocele, ectopic adrenal nests, inguinal hernia, supernumerary testis, and testicular neoplasm. Okay, it shows you can differentiate by the physical exam, by the imaging, which is mostly ultrasound, and this shows how much or the epidemiology or the incidence of each problem. So testicular torsion, the physical exam ranges from swelling with discoloration to small atrophic tests. And imaging, of course, there will be heterogeneous texture with lack of blood flow. This is the ultrasound findings. And this represents 12% of the pediatric torsion. And then the hematoma will be blue discoloration. And the ultrasound will show that there is a homogeneous echoic fluid surrounding the testis. And it's due to trauma, usually if the baby is breech. Hydrocele, of course, you can do the transillumination. And with transillumination, you can diagnose hydrocele, which is a benign condition, and it will resolve on its own. And you can feel the normal testicle, and it does not need any intervention. And then the hernia. The hernia, there is a mass. We don't have any mass in this case. Questions? Comments? And then we have a third MCQ, which is important. Okay, are you ready for the third MCQ? Let me check the chats and see if you have any comments. Right. Dr. Abir, yes. Yeah, I'm sorry, I was confused between both right and left testicles in the last MCQ. Excuse my age and my memory, but the right one was the one that presented clinically, and both presented by the ultrasound and by surgery. And they could save the left testicle, they couldn't save the right one, and they took it out. Okay. MCQ number 3, which is extremely important. You have to keep this in the back of your mind. This is a very important clinical presentation. It's a serious one. So we have 2 kilogram and 9 grams, 90 grams, male infant, was born to a primate that had initially monochorionic, amniotic twin at 30, the baby was born at 34 weeks. And they did C-section for presumed fetal compromise. What happened is one of the twins vanished. There was vanishing twin syndrome. It was a cardiac amorphous second twin. The baby had no heart and died, the twin. Antenatal scan showed that the one that we are talking about had muscular VSD, and mom received antenatal steroids. Baby had some transitional respiratory distress, received some CPAP, and everything looked appropriate as far as we are doing examination. Except for some, there was flat forehead overriding of the parietal and temporal bones. And okay, on day 2, the infant had 3 episodes of focal seizures. Oh, you know what? This is not the No, this is not the one I need to discuss with you. I'm sorry. Because I read all these and I see if they are appropriate to present or not. And some of the cases might not be appropriate for us in Egypt. Okay. Yeah. This is another easy case, but the diagnosis will be very astonishing to you. This is a term baby had bilateral scrotal swelling, immediately noticed following delivery. Immediately noticed. The prenatal and birth histories are not significant. Everything looked okay. There is no consanguinity. The fetal ultrasonography at 34 weeks and 3 days showed normal anatomy, normal Doppler flow, and amniotic fluid index was normal. The baby was born at 37 weeks and 3 days. There was thick meconium and stained amniotic fluid with meconium. This is an important key point. Apgars were 8 and 9. Soon after birth, the infant scrotal sac was noted to be swollen. Immediately after birth. This is important. The timing is important, and it was both sides. Baby hemodynamically stable, but everything looks not nice except for those two bilateral scrotal swelling. And the size of the scrotal sac was increasing. Vital signs, heart rate, respiratory rate, blood pressure, everything looks fine. Birth weight was 2,860 grams, length and head circumference within normal range. Abdomen is soft, this is more important. Non-tender, normal bowel sounds, no hepatosplenomegaly. Okay. As we are going to see in figure, there is a swelling present over the left inguinal region with gross scrotal swelling measuring 8 by 6 by 5, greenish black skin, discoloration. Bilateral scrotal swelling is soft, non-tender, soft, non-tender, with no erythema and able to be transilluminated. Transillumination is one of the very important diagnostic procedures we do in neonatology. And we use it for the scrotal swellings, we use it for the head, we use it for the chest, for pneumothorax, and it's very, very useful tool. So bilateral testicles or testes are palpable. This is extremely important. They are soft, with the left still undescended. And it was non-retractile at the lower inguinal ring without tenderness. The penis was buried, but normal length. And one of the important examination that you do for every and each baby is you check the length of the penis. And you should know how to check it and what is the normal for every gestational age, because if you diagnose micropenis, it is a big story. So this is what they did. This is the mass on one side, and also it is bilateral. And this is transillumination. For normal transillumination, like as you see in hydrocele, all the scrotal sac should be transilluminated. If part of the sac is dark, this is not normal. There is something wrong. And this is going to rule out hydrocele. So Differential. Again, it's easy because we said most of the differential with the previous case. What is your differential? How different torsion from epididymoorchitis? One of the question, how to differentiate torsion from epididymoorchitis in the newborn baby? I don't know if we can meet cases of epididymoorchitis, but usually with the epididymoorchitis, the testicles are enlarged, and also the epididymis, and they are very tender, and the baby usually is general condition is not good. It's not good. Have signs of infection. Okay. So we have here in the differential diagnosis, inguinal hernia, yes. A massive inguinal hernia, yes. Incarcerated inguinal hernia with hydrocele, a possibility. Incarcerated inguinal hernia, leaking of meconium in the scrotum. Who said that? Dr. Abir Tolba. Why you think it is that? Leaking of meconium in scrotum. Why you think this is your diagnosis? And what do you call this condition? Abir.
افتح المايك يا دكتور عبير عادي.
Due to history?
thick meconium يا دكتور.
Yes, but it is not secondary to thick meconium, as we are going to see. It is secondary to something else, meconium peritonitis. And
Yes, yes,
and
I
perforation.
the nominal.
There could be meconium peritonitis, and meconium peritonitis is because of perforation, and perforation most of the time is because of a small atresia, ileal or duodenal, most of the time ileal atresia. But this is a very smart thinking. Let us see what is the differential. This baby was clinically stable with bilateral. This baby was unlucky. With the left greater than the right. Congenital hydroceles, and we ruled out with the transillumination. And with the hydrocele, you don't see this, because this is an inguinoscrotal swelling, and the hydrocele is a scrotal swelling. So it is not hydrocele. Inguinal hernias, maybe it could be bilateral inguinal hernias with some hydrocele, as you said, but there is something wrong here. Meconium periorchitis. This is the diagnosis that Abir mentioned, but she didn't mention this term. Testicular teratoma. Yes, but bilateral, this baby would be very, very unlikely. So, yes, it's not hydrocele, it is not hernia, or it's not a simple hernia. There's something wrong. It's more than hernia. Teratoma, we don't know. Meconium pericarditis, it's a very good possibility, although it's very rare. Okay. They did CBC and DEF, which is normal, which will rule out sepsis, epididymoorchitis, as one of you asked about the previous case. So it is not infection. And this is the clue. They did abdominal radiographs. There was bilateral calcifications over the scrotal region are noted. So the scrotum has calcifications on ultrasound and on X-ray and on CT. So they noted calcifications on the X-ray of the abdomen and of the scrotum. So they did ultrasonography, which is very helpful. And at some point, we need to do a lecture about ultrasonography in the newborn baby, which is extremely important. And now you can use it for diagnosis of many, many diseases. And even for insertion of lines or for doing a lumbar puncture. So it is a very interesting topic to talk about, ultrasonography in the newborn baby. Okay, scrotal ultrasonography showed large fluid-filled collection with calcifications. And when you see calcifications in a newborn baby, in the abdomen or in the scrotum, this is a diagnosis of meconium peritonitis. And meconium peritonitis is secondary to perforation in utero. And for perforation to happen, there should be some type of atresia, maybe very small. And usually with the perforation, the problem is solved and you don't need to do surgery, but it could extend to the scrotum and cause some problem to the neonatologist, and you need to know how to deal with this problem. Okay? And then also abdominal ultrasonography showed free fluid in the left paracolic gutter with an internally altered echo texture because of tiny calcifications. And septation, one calcification is noted surrounding the capsule of the liver, because they divide ultrasonography of the abdomen in case of meconium peritonitis into grades or stages, 1 and 2 and 3. This might be more important for labor and delivery guys. Okay. And then they did a CT of the abdomen and pelvis, which confirmed the presence of these calcifications. They did a CT, which showed calcifications, scrotal and abdominal. So, what was the actual diagnosis? Meconium periculitis, secondary to meconium peritonitis. The baby was hemodynamically stable, and there's following up the baby course, there was gradual reduction in the scrotal swelling. So you just manage it conservatively. No surgical intervention, no topical issues, just observe. And the idea is that to be sure that there is no compromise to the testicular vascularity. Because if this happens, this is something serious. So this baby needs follow-up with the echo Doppler to be sure the blood flow for both testicles is good. Otherwise, if it is compromised, here the surgeon should interfere and to save the testicle and prevent sterility if it's bilateral and endocrine problems. Okay? How meconium periculitis occurs, it's a complication, as we said, meconium peritonitis. It is 1 per 35,000. And it divided into type 1, type 2, type 3. The meconium peritonitis is 3 types. If there is large meconium ascites, if there is large pseudocyst, if there is intra-abdominal calcification, small meconium ascites, and or shrinking pseudocyst, this is what we saw in this case, most probably, without pseudocyst. Okay. Intrauterine perforation, chemical peritonitis, and other authors suggest 3 other possible mechanisms for these meconium entering into the scrotal sac, how it enters into the scrotal sac, because of fetal intestinal perforation, and it will go through the processus vaginalis into the developing scrotum, or intestinal perforation near an undescended testicle, followed by adherence. This is all theories, or necrosis or perforation of the strangulated portion of the fetal intestine. So, small bowel atresia most probably is the cause. It's managed conservatively, but you have to follow up this baby for blood flow of the testicles. Okay. Why it is not teratoma? An infant with a testicular teratoma presents with a firm mass with ultrasonography and demonstrates multi-septated cysts. So you can diagnose teratoma and differentiate it from peritonitis by the ultrasound. Testicular torsion, we talked about that. We talked about hydrocele. So MPO is an uncommon that consists of mass-like scrotal lesions caused by in utero passage of meconium into the scrotal sac. Calcifications in the scrotum seen on ultrasonography are the hallmark of this benign condition. Differentiation from other concerning causes, a paratesticular mass is important and can avoid an unnecessary orchid. Yes, because if you suspect like teratoma and you don't do enough investigations, or you think it's torsion and there is interference with the blood flow and the surgeon suggests orchiectomy, this is a catastrophe. You are getting rid of a normal testicle for no need. Okay? I will look at your chat and then we'll start giving you some cases. But before we move to cases, inflammatory leading, okay. Before we move to cases, I need to see your feedback. I need to know your feedback.
Doctor, I have a question in the last case.
Just 1 second, 1 second. One second. Yeah, go ahead. If you hear me, go ahead.
Yes, I can hear you. About the last case,
You don't hear me?
I can hear you.
Okay.
About the last case, should I suspect meconium peritonitis without any history أو يعني no collapse مثلا, no abdominal distension?
This happened in utero.
Mhm.
You don't see this as a neonatologist. You see this as a obstetrician. When you are following up your pregnant lady, you at some point you might find evidence of meconium peritonitis calcification in utero. Or if the baby is born, you will notice this, but this is an event that happened in the past. The baby at this point is not having meconium peritonitis. When you see the baby, do you get that?
Okay, the question is why didn't I suspect the other causes of calcification?
Like what?
As you said, there was calcification in the abdomen. I thought about Wallman disease مثلا as a metabolic disease.
I don't say it again. What is Wallman?
Wallman, yes. It causes calcification in the liver and the adrenal glands and in other sides of the body.
So you said that difference by yourself. You said calcifications in the liver and adrenal glands. We are not dealing with calcification in the adrenal glands or in the liver. We are dealing with meconium peritonitis in the peritoneum, maybe surrounding the liver, yes, but otherwise there is no other calcifications, maybe in the scrotum, and that's it. So why you think of a very remote possibility?
I just thought about it when you said calcifications around the liver, so I thought about more investigations to rule out.
I don't know, but usually we try not to do unnecessary investigations as much as we can. And the more you narrow your differential, the more you make less lab works and make less money spending. But yeah, if the case was just abdominal calcification, maybe you think this way. Yes.
Thank you.
You will. Chat. I need your. If you don't have mic, raise your voice. This is. Does cystic fibrosis excluded as possibility of Meconium ileus? Causes no. If you have a baby with Meconium ileus, you have to rule out cystic fibrosis. This is important.
And the case did rule it out, sir. The case did ruled out by immunotrypsinogen was negative, but we did skip it.
Oh, okay. Maybe I skipped it because it was not one of the keywords. I tried because if I read every and each word, every case will take us like 2 or 3 hours, which is not fair. And it will be a lot of information, too much it's heavy dose and heavy meal. I try to focus on the keywords and the diagnostic approach and the homegoing lessons. But eventually I send all these MCQs to you, and you can read it carefully and in details at your ease. Okay. Can we move to the case? I didn't get your feedback. What is your feedback?
How can we improve and such?
Yeah. What is your?
We are speechless, Prof.
Yeah. Raise your voice and yeah, keep going.
We are speechless. The lecture is very informative and interactive. Thank you.
Is there something wrong that I made and you need to improve in addition to these memory losses issues?
No, we are learning from.
Okay. You think it's beneficial and we can keep going in the next meetings the same way? Because I have a lot of MCQs.
Yes, Prof. Go on.
Sorry?
مفيدة جدا يا دكتور. مفيدة جدا يا دكتور.
Okay, sir. Thank you very much. Then I will move to the case discussion, and we have the same attitude. Smart diagnostic approach. Okay. We have a pregnant woman at 36 weeks. She had spontaneous uterine contractions, abdominal pain, amniotic membrane ruptured 16 hours. I cannot highlight any word because this is the snipping and it does not allow me to highlight, but I will use the arrow. Okay. 16 hours. This is one keyword.
Could we full screen, Doctor?
Full screen. Okay, sir. I'm sorry. Full screen. Because I have a window here that's silly. Full screen. Okay. Slideshow. Okay. Slideshow from current slide. Okay. Yes, we can start now. 36-weeker. Mom had spontaneous uterine contractions and abdominal pain. Amniotic membrane, 16 hours rupture. Bloody, foul-smelling fluid. She has tachycardia and temperature of 38.5 and uterine tenderness. This is a classical case of
chorioamnitis.
And the goal beyond this case is to attract your attention to the chorioamnitis, because I feel that you don't take it seriously. From my discussions with our friends in Sharp E.U.P for 2.5 years now, they don't mention chorioamnitis too much. They don't think of it too much. And because of lack of communication, which I tried to solve, but I couldn't, between NICU team and labor and delivery guys, there is no much talking about chorioamnitis, which is a very serious and important article and issue to deal with. It is the most common cause of preterm labor. It is a very bad risk factor for IVH, NEC, and BPD. So one of the issues that I need you to know, maybe you will try to ask the guys in the liver and delivery to do it, is placental pathology. This is what I used to do here. Whenever I have a case of suspected early onset sepsis, immediately I ask the labor and delivery guys, before they get rid of the placenta, please send placenta for pathology. And placental pathology is extremely informative and very, very, very helpful. Actually, you don't do it yourself, but at least when you have the report on the maternal chart, you should know what you are dealing with, what you read, what is pneumonitis, what is villitis, and so forth. That's why I got this case for you. Apgars 5 and 8, 4 hours after birth, the unit is lethargic with a temperature of 36. Oh, a respiratory rate borderline, heart rate 170, which is high, complete CBC and F cell count of 35,000. So this is a very suspected case of early onset sepsis, correct? And the mother definitely had very suspicious chorioamnitis. So I will give the labor and delivery guy a phone immediately. Sir, please send the placenta of baby X for pathology. And please send the results to us as soon as possible. The pathologist examined the placenta. Of the following, the most likely histopathologic finding in this placenta is chronic villitis, decidual vasculopathy, pneumonitis, syncytial knots. If you don't know the answer, try an educated guess. And what do you think is the correct answer? C. Suhair said A. And Asma C. I see somebody saying sepsis. I don't know what do you mean by sepsis? This is not one of the options. SCK said so. A, pneumonitis, C. So you are most of you between A and C. Okay. Pneumonitis, it's C. It's the inflammation of the umbilical cord. This is extremely important sign. That's why every neonatologist who attends a delivery should look at the placenta. And if you suspect early onset sepsis, please, doctor, obstetrician, send the placenta for pathology. It's caused by neutrophils of neonatal origin. It is part of fetal inflammatory response. So it is a sign of, it comes from the fetal side. it is sign of early onset sepsis. This is extremely important. Chronic velitis is something totally different. It's not non-infectious graft versus host disease or reaction caused by infiltration of mononuclear lymphocytic cells of maternal origin in response to a fetal antigen. Is associated with growth restriction. So this is the importance of the chronic velitis. If this happens, this can cause fetal growth restriction, because many times we have a baby who is SGA or IUGR, and we don't know the reason. And almost always we think of CMV, but it could be because of chronic velitis. I will not go into much details, but this is the homegoing lesson. Think of chorioamnionitis, the most common cause of preterm labor. It's a risk factor in preterm babies for IVH, NEC, and BPD. Ask for placental pathology and know how to interpret the results of the pathology when it's sent to you. And the most important sign is pneumonitis, meaning early onset sepsis of the newborn. And if I have an IUGR baby, you might have chronic velitis. And I will show you some pictures, histopathologic pictures. This is for pneumonitis. And yes, the same picture. This is vesiculopathy. And this is the chorionic villi are enlarged. Yes, this is chronic velitis, which can affect the growth of the baby, of the fetus. Okay. Any question? Any comment? I will try to finish the second case before the 2 hours end. Any comments? Questions? As you said, Prof, such a case can be prevented only by good communication between us. Yes, you are right. How does the placenta look like to suspect pneumonitis? Okay, let me go back to the question. Okay, I will go back again to this question. You don't know what? You know what? Oh yeah, critique. Chorioamnionitis, also known as intraamniotic infection, is a complication occurring in approximately 1 to 5% of all births. 1 to 5% for in every 100 babies, you have up to 5 babies whose mom had chorio. It is commonly associated with preterm delivery in 40 to 70% of cases, and sometimes it is asymptomatic. The clinical presentation of chorioamnionitis is non-specific and includes maternal fever, leukocytosis, uterine tenderness, foul-smelling amniotic fluid, and fetal tachycardia. However, almost 30% of women with chorio are asymptomatic. Risk factors for chorio include untreated maternal GBS, prolonged rupture of membranes, as we had in this case, cervical insufficiency, vaginal examination, too much instrumentation, and in the vignette, the history is okay going on with chorio. In the setting of chorio, gross examination of the placenta may reveal yellow, green placental membranes and the presence of a foul odor This is the clinical findings you can see in a case of choreo when you examine the placenta. This is the answer for your question. And then comes the phenicitis. You have to diagnose it histologically. It's a histologic diagnosis. Okay. In response to inflammatory stimuli, neutrophils from the fetal circulation may migrate into the chorionic vessels and the umbilical cord, especially the vein and artery, followed by the Wharton jelly. Umbilical cord involvement is known as phenicitis. Did I answer your question? Phenicitis is the placental finding most associated with early onset sepsis and most likely histopathological find. Okay, it is a histopathology, but the placenta, as we said, there might be yellow, green placenta membranes, and presence of foul odor, and then comes the histopathology. Okay. Did I answer your question? I hope yes. Vaginal swab in prom to feverish mother, only appropriate antibiotics. If clinical signs of choreo are present, please, what is the value of pathology? Because this is the gold standard. You cannot swear to God that this is 100% chorioamnionitis based on clinical, but you suspect it. You suspect it. But either you do culture and get the organism or do histopathology. This is the gold standard. Okay? Keep going. So what happened? Yeah. I think I'm back to MCQ again, but this one is important. So I will do it. I know it's an MCQ, it's not a case, but I will do it. I will do it. So this is a term, 40 to 100 grammar. Mom had gestational diabetes, born via C-section because of the fetal bradycardia, and baby was intubated, and mechanical ventilation started. Findings of cord gas and neurologic examination are consistent with moderate encephalopathy, and whole blood therapeutic hypothermia is initiated. Antibiotics intravenous, so on. On the second day after birth, the neonate has persistent anuria. This is one important key point. Poor perfusion. Baby started to be shocky. Abdominal distension. Oh, baby is very sick and there is something wrong in the abdomen. Palpable mass. Oh. Okay. So you should think of what is the differential diagnosis of masses in the newborn baby, and then what is the differential diagnosis of a mass in a very sick newborn baby who is intubated, ventilated, infant or diabetic, has persistent anuria, poor perfusion, and is shocky, and abdominal distension. Here is your differential. And then grossly bloody urine is obtained after placement of a Foley catheter, and then we'll discuss the labs. What is your differential at this point? I think it's easy now. Term baby, a large baby, infant or diabetic, intubated and mechanical ventilation, encephalopathic, had HIE and had hypothermia, antibiotics. Baby is very sick, shocky, has urinary issues, anuria, abdominal distension, mass, grossly bloody urine. There is something wrong in the urinary tract. And then we look at the labs. What is your differential? And then after what differential, what is the most common cause? Renal vein thrombosis, renal vein thrombosis, renal vein thrombosis, posturethral valve, posterior urethral valve. Who said that? I see. Posterior urethral valve, PM. Who is PM? Why you thought of posterior urethral valve?
دكتور عشان في سوبرا يعني عشان في ماس في اللور ابدومين
احنا ما قلناش لور اب، احنا قلنا abdominal mass.
abdominal not pelvic
Yes, we
mass.
said palpable abdominal mass.
تمام.
And why there is blood in urine, why the baby is shocking, why the baby was very sick, why there is anuria, poor perfusion. So it is a possibility, but it is not like on top of the list. Search for sacral agenesis. What do you mean by that, Dr. Abir? Sacral agenesis. What is your idea?
It's يعني very associated اللي هي Mermet sign مع ال infant of diabetic mother بيبقى فيه sacral agenesis.
Yes. How could it present? Does it present this way?
No.
I'll see بالإكس-راي بقى ما يعني
Clinically, does sacral agenesis present this way? The baby will be very sick, anuric, blood in urine, abdominal mass, perfusion. Why is that?
trial of
لا as association انا بتكلم انا قلت renal vein thrombosis بس بتكلم ان احنا ندور على other associations طالما في anomaly موجودة.
Keep to the point. Don't get yourself distracted. If you think of hundreds of diagnoses, you will not make a good decision. We need to do a very sharp, rapid, immediate decision based on immediate diagnosis and differential and what on top of the list. Renal vein thrombosis was very appropriate. Poor urethral valve, renal is hemia. Renal is hemia. What do you mean by renal is hemia? I don't know.
دكتور هشام معانا ودكتور محمد توفيق معانا دكتور.
Welcome, sir. Welcome, dear friends, dear professors. So, yeah, most of you said renal vein thrombosis, polycystic kidney disease. Dr. R, please, why is that? Does polycystic kidney disease present this way? Baby who is infant of diabetic mother is very shocky, had initial HIE and cooling, is on the ventilator, has anuria, blood in urine, poor perfusion, abdominal distension, abdominal mass. So because this baby had abdominal mass, you will think of polycystic kidney disease and you ignore other symptoms and signs. I don't think this is a good choice. Polycystic kidney, bladder distension due to neurologic impairment. And why there is a neurologic impairment? I don't want you to think of remote possibilities. What you do is, when you think of any question or case presentation, it is like a puzzle. You have key words. You should be smart enough to know what are these keywords. And then you collect them one by one by one. Then you build the whole picture using those pieces of the puzzle. And then you build your own differential diagnosis and what is on top of the list and what labs do we need to do? What can we exclude? What can we confirm? This is the smart clinical thinking. But if you think of every disease that can, like if you think of 100 diseases or 200 diseases for the, to explain what is in this case, you will get lost. You will get lost. So bladder distension due to neurologic impairment. So you are having a microscopic vision now, looking at abdominal mass and the other signs you don't care about. No, this is not the way you think of this problem. Renal ischemia due to HIE. Renal ischemia due to HIE. This is a very good thinking, but why there is a mass? HIE can cause renal failure, yes, can cause anuria. But why there is poor perfusion, why there is blood in urine, and why there is a mass? It doesn't answer all these questions, but it is a possibility. MCC, I don't know what is MCC. What is MCC? Meconium, what is MCC? What is MCC? R. Dr. R, what is MCC? PKD. What is PKD? Phenylketonuria? I don't know what is this. Hypoxia can be the cause of what? So this baby is just HIE and that's it?
Wilms tumor.
Wilms tumor? Does it present that fulminant, acute, sharp, devastating presentation? Does Wilms tumor? It's usually asymptomatic. It's just discovered accidentally. When you do careful examination, you find a mass, and then you start looking for the mass. Ask the mother about issues like blood in urine, yes, but it is not that fulminant. Maybe due to UVC and intervention as a complication. This is not a diagnosis. This is an explanation. What do you? Yes, we know it could be due to the UVC if it's a renal vein thrombosis, but this is not a diagnosis. Wilms tumor, DDRD. Yes. Adrenal hemorrhage. Yes, it's a very good thinking, Dr. R. Yes, adrenal hemorrhage. It can be can occur in HIE. Yes, in very sick babies. Yes, can present with shocky baby. Correct. A mass. Yes, but why blood in urine? Why blood in urine? IDM, HIE, hypothermia, risk factor for bilateral, but this was only one mass. It could be, this baby could have bilateral, but it is a possibility, but in our vignette, it is unilateral. Agenesis by incontinence. I don't know what is this. Polycythemia in diabetic patient leading to renal vein thrombosis. Yeah, we are asking about a diagnosis. We are not asking about explanation. Wilms tumor, factors predisposing to, we'll discuss factors now, but not, this was not my question. Okay. Let us look at the labs. I have a question for Dr. Amir and Dr. Ahmed. Are we limited by the time I have to stop immediately after 2 hours or what
لا
if I
لا
need
براحتك خالص، براحتك خالص يا دكتور.
ها؟
لا الوقت معانا يا دكتور، براحتك خالص.
طيب ريحتني because I'm trying to run. Okay. Thank you very much. Labs, sodium 148, it's high. Potassium is okay. Chloride, not bad. Bicarb, not bad. BUN, high. BUN is high. The kidney is creatinine 1.8. There is something wrong with the kidney. White cell count 26,000, mostly neutrophils. Hemoglobin is 20 because this baby infant of diabetic mother. Hematocrit 60. This might add to our problem. Platelets 83. So we have a combination, a triad of abdominal mass, hematuria, low platelets in a newborn baby. This equals renal vein thrombosis. When you say abdominal mass, hematuria, low platelets, it's a classical textbook case of renal vein thrombosis. Because the problem with the renal vein thrombosis, as we are going to see, sometimes it does not present with this triad. It does not make our life easy. So you have to be very cautious, very careful, and you have to be very suspicious. And when you have risk factors for renal vein thrombosis, don't miss it, please. Of the following, the study, so you are very happy and excited to know what is the diagnosis. But the question is not about the diagnosis. It is about something else. Of the following, the study, we are talking about study, with findings most likely to be diagnostic for this unit is to do renal contrast venography, to do renal ultrasonography with Doppler, to do urinalysis and urine culture, to do VCUG. A, B, C, D, and Y. And Y. B, 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 B. Okay, everybody is saying B, which is the correct answer. But nobody said Y. We'll see why. Now, renal vein thrombosis has 3 classical signs: hematuria, palpable abdominal mass, and thrombocytopenia, period. Patients with renal vein thrombosis often exhibit only one of the 3. Thus, a high index of suspicion is warranted. Risk factors for renal vein thrombosis include venous catheters, the UVC, conditions associated with increased blood viscosity, as in this baby, who is borderline polycythemia. It's not the number 60 is not enough, but it's borderline. It's not classic polycythemia. The number should be higher than that, and depends on what vein are you using, peripheral vein or a central vein. Some genetic thrombophilias, hypercoagulable states, and we discussed this in details, the hypercoagulable states. Ultrasonography with Doppler technique is the study of choice. This is the gold standard for the diagnosis of renal vein thrombosis. Why? Because of its portability, high sensitivity, and it's non-invasive. Management of renal vein thrombosis is not well defined, as most of the problems in the newborn. You will hear these words a lot. Challenging, diagnosis is challenging, management is not well established. There is a controversy about managing. This is the newborn medicine, unfortunately. And whatever we are doing in neonatology, unfortunately, is based on adult studies. But never mind, this is another story. Management of neonatal renal vein thrombosis is not well defined and remains controversial. Thrombolytic This is a treatment. Anticoagulant therapy is indicated for bilateral. So if you have bilateral renal vein thrombosis, you have to do something, because this baby might go into end-stage renal disease and might lose both kidneys. There is no, you don't hesitate. But unilateral, there is a debate. Treatment of a unilateral renal vein thrombosis with evidence of renal injury is less clear. And this baby had evidence of AKI, acute kidney injury. And there is a collaborative approach. You have to consult the urologist, the nephrologist, the hematologist, and yourself. And one of the good issues that we could achieve through our meetings is that we invite many of the pediatric subspecialties, and they were very willing to attend, and they appreciate our invitation, and we appreciate their attendance because they enrich our discussions. We had the cardiologist, the urologist, the nephrologist, the endocrine, the nutritionist, the geneticist. We have pulmonologists. We have a lot of help from those dear friends. Critique. The neonate in the venette has renal vein thrombosis, which is the most. Now?
Excuse me, Prof. If this baby on cooling therapy, shall we continue or to stop?
To continue the cooling therapy?
Or stop?
I don't think we'll stop it. Why should we stop it?
So we will continue.
We are trying to save the brain.
So we will continue even with this condition.
Yes, I believe so. Let us look and see what did they do. Maybe they did something different. But if I was the one taking care of this baby, I would keep going. It's the most.
Does this child have hypernatremia?
Yes, his sodium is high. Yes, and this is part of the renal injury, AKI. Yes.
Yeah. Okay.
What is the question? Okay. It is the most common non-catheter related thromboembolism in neonates. So if you rule out the catheter causes, it is the most common thromboembolism in the neonate. It occurs in approximately 2.5 per 10,000. Although relatively rare, renal vein thrombosis has a high morbidity. Most neonates experience one of three classic signs: hematuria, gross or microscopic, blank mass, and thrombocytopenia. Less than 25% of affected neonates experience the complete triad. Renal vein thrombosis occurs more commonly in males, most cases unilateral, with a left-sided predominance. We don't know why. Approximately 40% of cases show extension. This is serious complication, and it can affect your management, even if it is unilateral. Extension of the thrombus into the inferior vena cava. This is very serious. You have to interfere. 15% are associated with adrenal hemorrhage. So the doctor who thought of adrenal hemorrhage was very smart. And it could be an association, by the way. Associated acute kidney injury is common. So we have renal vein thrombosis, usually associated with AKI and maybe adrenal hemorrhage. It's a very complicated issue in this baby who is already very sick and is on hypothermia. Associated acute progression of renal vein thrombosis may lead to the development of systemic hypertension. Yes. Distant embolization, chronic renal failure, renal atrophy, these are the complications. Approximately 7% of cases are diagnosed in utero, but most patients exhibit signs in the first 3 days after birth. To make a prompt diagnosis, a high index of suspicion is warranted. Okay. Neonates have a higher incidence of thrombosis in general because they are more on the side of hypercoagulable state compared to the side of bleeding or coagulopathy state. They have more tendency for hypercoagulability than older children and other children and adults, because they have decreased plasma concentrations of anticoagulants, protein C, protein S, antithrombin, and fibrinolytic agents like plasminogen. Okay. Because, okay. The neonatal kidney is also susceptible to thrombosis because of the low perfusion pressure. This is related to immaturity in the newborn baby. Vasoconstriction caused by high catecholamine, endothelin, and angiotensin II. If you go into academia, we'll discuss this in details. Why the kidney is more susceptible to injury, why the renal vein thrombosis is more common in neonates compared to older children and adults. We discussed this when we talked about bleeding disorders and hypercoagulable states. Spontaneous or non-catheter related RVT is believed to begin in the arcuate or interlobular vein of the kidney and extends in either direction to the renal cortex and main renal vein. Risk factors and conditions associated with increased blood viscosity, such as perinatal asphyxia, maternal diabetes, prematurity, hypovolemia, septicemia, cyanotic heart disease, etc. Renal vein thrombosis associated with umbilical venous catheter is likely caused by catheter-related endothelial injury, and it's one of the complications. Okay, also the factor C and S deficiency, protein C and S, factor F Leiden deficiency, all these are predisposing factors. Diagnosis is confirmed, of course, by the ultrasound. Renal contrast venography was the gold standard at some point, but it is now used only rarely if you don't have the ultrasound because of the exposure to radiation and contrast agents. But the renal ultrasonography with Doppler is the gold standard, and the management is not well defined, especially in unilateral. But if it's bilateral or extends to the inferior vena cava, you have to manage thrombolytic treatment, anticoagulants, thrombectomy, whatever, medical, surgical, depends on the case. These are sequential ultrasonographic findings associated with neonatal renal vein thrombosis. They divided into stage 1, stage 2, stage 3. And I know that you use the ultrasound for the lung problems, for the head. I don't know if you use it for the kidney or not, for the renal vein thrombosis. So I don't know if these stages are important for you or not, but I will send it to you at some point. I'm done with these questions. Do you need another case, or we can stop here? We are almost 10 minutes, less than 2 hours. 1 hour and 50 minutes. What do you need? نكمل stop. طيب نكمل stop 50-50. طيب نكمل stop. Okay, I will stop because the stop is more than نكمل. 5 stops and 2 نكمل, I'm going to stop. Next week, inshallah, Saturday, Dr. Manal Said will discuss with us the newborn rashes. And I believe she will give us a very good presentation. Newborn rashes is extremely important. And sometimes for the best neonatologists, most experienced neonatologists, sometimes they are in dilemma when they face a newborn rash, which may be, the idea is it benign or it's concerning? Because if it's concerning, the management will be totally different. It's benign, you will just assure the parents and forget about it, and it will go and disappear on its own. Before we leave, any comments, any feedback? I know because of the memory problems, I might have confused you going back and forth between MCQs and cases, but next time I will try to be more vigilant about
شكرا جزيلا يا دكتور، يعني وقت رائع مع حضرتك، تسلم ايد حضرتك، شكرا جزيلا.
الله يخليك ويبارك فيك. I hope we will meet إن شاء الله كتير and Saturday الجاي إن شاء
شكرا
الله.
جزيلا.
إن شاء الله يا
شكرا
دكتور.
دكتور.
الله يخليك ويبارك فيكم. And when I am done with all this, I will send it to you, Dr. Amaro and Dr. Ahmed, and then you can distribute it between all of you. And also you can have this presentation on YouTube for any person who is interested. And thank you very much. I appreciate your attendance and your communication and your response. And see you, inshallah, next Saturday. Bye bye.
إن شاء الله يا دكتور، شكرا، في رعاية الله،
Bye bye.
مع السلامة.